So I can chat about our 13-year experience. And I'm honored to be here today. So with that, we'll go ahead and get started. Let me just make sure I can. Yeah. Okay. So we'll go over the rationale for why we do PAOs. I'll review the historical perspective. We'll discuss the evolution of our technique, talk about combining arthroscopy and PAO, some of the technical considerations, lessons learned, and then future considerations. I did this before. I'll do it again. I'm not sure how many people were here last time I presented. So for me, this is close to home in terms of the origins of the PAO. So Reinhold Gans was the lead author when it was published in 1998. And who is the other lead surgeon on the publication? Ben, you're not allowed to answer. Does anyone else know?
Fellow level. Crickets
No.
here. Crickets.
Crickets. Okay. Well, it was Jeffrey Mast, actually, who at the time was a surgeon in Detroit, which is where I trained. And if you are doing PAOs, it's interesting. Jeff Mast and Reinhold Gans were the ones who really invented the procedure. And in the PAO set, the technical instrument set, there's a Gans osteotome and a Mast osteotome. And the Mast osteotome is a curved version. The Gans is more of an angular version, a technical point. But, in essence, you had two different minds approaching this same problem. And I think it's fair to say that they probably had a little bit of, maybe technical disagreement about the best way to do it. But the roots are in Switzerland, and in terms of the United States, actually in Detroit, which is where I trained, and that explained a lot of the early influence in my career. And that leads to question 2: in what city was the other author a full professor? Everyone knows Reinhold Gans is from Bern. It's called the Bernese osteotomy, but Jeff Mast was working in Detroit at the time. So thanks to my mentors, Mike Millis, Young Joe Kim at Boston Children's, Stephen Murphy, and then Ira Results in Detroit, who inherited, I think, a number of Jeff Mast's patients. So Ben and I, first met in Switzerland in 2006, and was a big reason why I came to Chicago and began this amazing collaboration. And look forward to this continuing. So I think a historical perspective is helpful. I think there's a lot of things we take for granted when we do PAOs now. I think it's important to understand why the PAO was developed, specifically, obviously with the background of dysplasia being the dysplasia and instability being the problem. A PAO was not the first operation to address hip dysplasia. So I think it's helpful to understand why they made the leap that they did for the PAO. What was technically different from the PAO about previous surgeries that were done? Oh, there's everybody. Morning.
A better perspective.
Yeah, everyone looks so orderly and disciplined, which is great. Okay. So there were other operations that were done to address hip instability and the lack of appropriate coverage. Shelf osteotomies were well described in the pediatric world, and I think, Ben, are you still doing an arthroscopic version of this today?
Very rarely. We've done it though, yeah.
Yep. So, shelf osteotomies, Chiari osteotomies, Salter osteotomies out of Toronto, steel osteotomies, spherical osteotomies, largely out of Japan and Germany. All these different techniques were utilized to really achieve this with the end goal being the same, trying to achieve additional acetabular coverage. And I think they achieved varying degrees of success. And it's important to kind of recognize the limits of each of these types of osteotomies. For example, you'll see the shelf osteotomy that's pictured on your screen. It utilized really morselized buttress bone grafts. So essentially they were packing, particulate matter with the hope that would ossify to some degree. So you really had a disconnect between what you were putting in and then what you were trying to achieve. You were, relying on biology. You were assuming that it was going to heal in a manner that you wanted, both in terms of density and congruency. And so there are really a lot of limitations in the shelf osteotomy. Similarly with a Chiari, Salter, and steel, you were basically making a single plane osteotomy and trying to kind of pull one portion of the pelvis in a single plane to cover. So there were really some distinct limitations in the early efforts to correct coverage deficiency issues. So when you look at the next evolution, which was the steel triple innominate osteotomy, this is, really starts to come close to what we technically do with the PAO. So Steele pioneered these, 3 cuts of the ilium, of the ischium, and the pubis. But the real key here is to look at the osteotomy site in the inferior pubic ramus. And here, the acetabular fragment is entirely disconnected to the pelvis. And the challenge here, there's really 2 challenges with this method of correction, is that number one, you have limited mobility. You have that big ischial fragment. The hamstrings are attached to that. You're going to have challenges really in the ability or magnitude with which you can correct. And secondly, in this case, the posterior column of the pelvis is disrupted entirely. In essence, you're creating a pelvic discontinuity by doing this case. And so those patients had to be in a spica cast following surgery, which is major inconvenience, slows rehabilitation, and puts them at risk for non-union in these cases. So there was definitely a role to improve this operation. Dial osteotomies, Heinz Wagner in Germany was a big proponent of these, as well as surgeons at Sugioka in Japan. And in essence, this was an effort to create a more powerful correction with perhaps a smaller fragment being mobilized to enable a little bit greater magnitude of correction. But even with this, you had some significant limitations in terms of where you could place the fragment and the degree of coverage that you could achieve. So with all these things in mind, your goal is to achieve a powerful correction. So you want to make sure you can move the acetabulum as much as possible to correct large deficiencies in acetabular coverage. But you also wanted to maximize potential for healing and reduce time to rehabilitation. And that was really those were the 2 keys that led to the formation of the Bernice periacetabular osteotomy. The goals of this osteotomy were to achieve a number of different things. So lateral coverage, anterior coverage. You wanted to be able to correct version. And I think this is even more important as I look at the operation today, where we're doing this, I would say, for maybe broader indications. For example, isolated wall insufficiencies. You really want to be able to move the fragment freely and not just achieve this lateral coverage that's going to make you feel good looking at an x-ray, but you really want to be able to obtain a versional correction. So someone who has an isolated anterior wall deficiency, someone who has a certain degree of pelvic tilt, all these things can be addressed now by a Ganz osteotomy. Your ideal correction will include some degree of medial joint translation. And the real key here is maintaining an intact posterior column of bone so that spica casting is not necessary and earlier weight bearing as possible. So the original technique is, a bit gruesome. It was a full ilioinguinal approach, really a long incision from the from the posterior superior iliac spine, all on the iliac crest, down through the Smith-Peterson interval, and distally. So it was a curvilinear incision. They dissected out the entire neurovascular bundle and the spermatic cord. There was a full takedown of the abductors off of the outer wall of the ilium, and a full takedown of the rectus. And even with this massive exposure that they were utilizing, you had a limited ability to look at your intra-articular structures. All these patients were, did preoperative blood donation. They were in bed for 2 days. They had an epidural in place. Whereas our technique now is much different. It's a modern technique. We utilize a bikini incision. In most cases, it's rectus sparing, and we're doing a hip arthroscopy in the same setting. Instead of taking the abductors down, we're making a small window underneath the abductors, placing a subperiosteal retractor, and protecting them while we do the iliac wing cut. So we're really trying to preserve, in essence, all of the muscular attachments while doing the correction. So as we look at the rationale for combined treatment, I think this is something where Ben and I were really in sync on. Most of these patients obviously are going to have mechanical overload from the insufficient acetabular coverage. That's the core indication for a PAO. But the indications for arthroscopy were patients who have loose bodies, labral tears, degenerative disease, chondral injuries, all these things, ruptured ligamentum teres. instability. And these are all things that you see in the setting of hip dysplasia. This was outlined nicely in a combined study from St. Louis and Detroit, showing that patients with acetabular dysplasia had a high prevalence of labral tears as well as chondral lesions. So you've got these people who have mechanical insufficiency, and the arthroscopic viewpoint enabled us to see that the vast majority of these patients are going to have cartilage lesions inside the joint. And so you might as well address it together. Ben and I published, along with the group from Boston, a follow-up study confirming these findings in our own patients, that all these the vast majority of these patients have intra-articular pathology. The things that we see commonly are labral hypertrophy. In these cases, so the labrum is large, kind of floppy, hypermobile. And in my own experience in Boston, we had a lot of patients after an isolated PAO coming back with mechanical symptoms. And I felt we would kind of diddle around with things. We would try SOS injections, intra-articular injections, but knowing what I know now, the vast majority of these patients had intra-articular pathology. It's important also to note that reduced head neck offset, in particular in males, exists in the presence of dysplasia. And your ability to manage this in the same setting, perhaps without an open arthrotomy, is a distinct advantage of this combined treatment. So this is actually our first case. This is a woman who had 3 arthroscopies. This is a nurse from La Crosse, Wisconsin. She had this bucket handle tear. It was no wonder that she continued to have discomfort. You can see she already had degenerative labral changes. I don't know about you, Ben, but I would have a little bit of reluctance in doing a PAO in this type of case now, but this was our first effort, and she did well, I think, for about 10 years, which I think was a significant win for her. So in terms of our modern technique, this is a bit of an older slide, but I needed a shorter video. So this really shows a little bit more of an oblique bikini style incision. This is perhaps a little bit larger than what we're using now. But we're dissecting to allow exploration of the Smith-Peterson interval. Here, we're starting to lift the external oblique from the iliac crest. And once we're able to lift their external oblique from the iliac crest, we do a subperiosteal dissection, where we're placing packing sponges down underneath the, inside the pelvic rim, essentially. And this helps us to achieve hemostasis. See if we can move this along a little bit. Once we've achieved hemostasis proximally, we work distally in the Smith-Peterson interval. We identify the reflected head of the rectus and often take this down to allow further mobilization. Here in this case, we took down the rectus, and then we're performing a subperiosteal dissection along the pubic ramus. We're placing a jiggly saw here underneath the superior pubic ramus, and we're passing it with a curved clamp, a Satinsky clamp. And then we're osteotomizing, the pubis, and then completing this cut with an osteotome. Here, we're osteotomizing the second cut, which is the ischial cut. This is an infraacetabular cut. The third cut is a power saw cut, osteotomizing the iliac wing. And then we deepen this cut utilizing a manual osteotome. Here, we're starting to mobilize the fragment. We're placing a Schanz pin. This serves as a joystick. And this is what enables us to complete our correction. So sometimes it's important to utilize a bit of manual force to break up the remaining small spicules of bone that are present prior to achieving your correction. So in terms of, just to explore some nuances of the dissection, I'm just going to go step by step here and talk about the different variations that you can do at each step. For your initial AS-IS osteotomy, a simple apophyseal division can be possible in immature patients. Different people use different methods of fixation here. You can use figure of 8 fixation with fiber wire. You can use a single cancel screw with a washer or multiple screws. Some people prefer a larger fragment here to allow increased exposure. As we move beyond that steps, we oftentimes will take down the rectus in larger corrections and in larger patients, for example, muscular males. But it's also important to consider your anterior inferior iliac spine morphology. In other words, if you're going to do a big anterior correction and you have a very prominent anterior inferior iliac spine, you can create extra-articular impingement. So if you see this going in, you have a prominent inferior spine, it may behoove you to take down the rectus initially. It'll make the procedure faster, and you may end up ultimately doing that anyway at the end if you have extra-articular impingement. It seems like in a number of cases, I think the reality for Ben and I working together is that there's a lot of cases that are borderline. So we will leave the rectus attached and then do a small peel at the end and a small, perhaps more conservative anterior inferior iliac spine recession with a burr, just to facilitate a little bit additional hip flexion and internal rotation. Pericapsular exposure can be used if you don't have the advantage of an outstanding hip arthroscopist. I haven't done an open exposure on a PAO to address pathology in a long time. Subperiosteal exposure is probably safer in most cases. It protects you from the neurovascular bundle, in particular the obturator neurovascular bundle when you're osteotomizing the pubis. Although extra periosteal exposure can facilitate healing because you're doing a little bit less soft tissue disruption and stripping. So if you're executing the pubic cut, which is our next step here, you usually want to be about 1 centimeter medial to the iliopectineal eminence. You want to be probably closer to the joint or closer to the teardrop, excuse me, in older patients. You want a broader surface area of the osteotomized cut to heal. The angle of this cut is approximately 15 to 30 degrees. In terms of your leg position, hip flexion, adduction, and then external rotation can be helpful to achieve exposure. I think this is still the most challenging part of the procedure for me, is achieving that medial exposure. There's a lot of stretch on the femoral nerve during this portion of the case. A lot of these patients will have a tight psoas muscle. And, quite frankly, there's a lot of dangerous things around here. So this for me is still the part that probably gets my blood pressure up the most. Your dangers here are the femoral and obturator neurovascular bundles. And you want to make sure you orient the cut appropriately. Failure to do so will really limit your mobility. In terms of the ischial cut, you're exploring the interval between the iliopsoas sheath and the capsule. The origin of this cut is 1 centimeter distal to the joint in the infracondyloid groove. You'll often find that your osteotome comes to a rest in this space. You want this to be perpendicular to the long axis of the ischium. Again, if it chisels off by 5 or 10 degrees, it can really limit your mobility. Gons or a mass chisel is probably best used here. There's some thought that the curved mass chisel may really impart a lot of stress throughout the pelvic ring and may predispose folks to stress fractures, in particular the posterior column. So I would say that the Gons osteotome, a more sharp angle, is probably favored by many surgeons at this point. Your sciatic nerve is a danger here, so it's important to make sure your assistant is positioning the limb appropriately. In terms of the iliac wing cut, Dr. Millis and Murphy, this was their modification, which I think really helped make a big leap forward, not taking down the entire abductors. It seems kind of like common sense now, but they were really the first ones to do that. For me, I think it's helpful to create a working slot manually. This is kind of my own modification, which really enables you a little bit more freedom and control in doing this cut, as opposed to just starting kind of point blank with a power saw. Your dangers here are your abductor musculature, as well as the greater sciatic notch and the superior gluteal nerve. Your cut location here is typically just inferior to the anterior superior iliac spine osteotomy, although it's more proximal and high-grade dysplasia, and people with a lot of anterior deficiency. And beware of the degree of extra-articular deformity you're creating. So if this cut is down closer to the acetabulum, you have a broader surface for healing, but the bone is much harder, so it's really and much thicker. So it's the closer you get to the joint, you probably heal faster, but it's actually probably much harder to execute the cut. The upside there is you have less articular deformity when you bring the fragment forward. In terms of your posterior column cut, the starting point is 1 centimeter proximal to the iliopectineal line. You're starting anterior to the sciatic buttress, that thick column of bone within the posterior column. I really am fussy when I'm doing this cut. I'll really take a lot of time to make sure that we're preserving the correct orientation and that the trajectory of the cut, I try and round it if at all possible to facilitate mobilization. In different types of pelvic anatomy, a real kind of tall, steep, narrow pelvis can make it really challenging to get your osteotomes in the right orientation. So I really take a battery of tools to this cut and try and perform it in an exacting manner if I can. And there's some newer osteotomes that have been developed that we've been fortunate to use that have really helped this. Your dangers here are your sciatic nerve as well as the possibility of a posterior column fracture. So this is the false profile view of the osteotomies in sequence. And you're noting, I will note that you maintain an intact posterior column here. So once you've completed all the cuts, you'd love for the fragment to move freely, achieve your correction, and then you can go home. But in reality, the final step here is probably the most tedious and time-consuming step. And that's really what I would call junctional cuts and fragment mobilization. Essentially, you're linking all these cuts that you've executed, and you're really troubleshooting to try and understand, the fragment, I would say, in a lot of cases, doesn't move the way you want it to move. And so then you have to troubleshoot based on your insufficiency of movement. Let's say you can't get a lot of anterior correction. Then probably it's your posterior column that's the issue. If you're really having trouble getting lateral coverage, it's probably the pubic cut or the lateral cortex of the ischial cut. So I think this step probably takes me as much time as the osteotomies themselves. You're really trying to make sure that entire pathway of the osteotomy is clean and allows appropriate movement. At this point, we'll place the Schanz pin, we'll stress the fragment, and make sure we understand where we're being limited. So what do you do if it doesn't move? And that's the million-dollar question, and that's something that I certainly have dealt with over the last 13 years. Some of the tricks include using a second Schanz pin, additional leverage points with a ball spike impactor, lateral pressure on the peritrochanteric region. You can place a hook in the cut surface of the pubic ramus to provide additional lift and force. You can take an additional wafer of the bone from the pubis. So all these things can be utilized to try and get this fragment to move the way you want it to move. Once you do achieve movement, it's all about assessing correction. And I would say that, the target for correction has been a little bit of a moving target over the years. There's a lot of focus now on what we would just call rim balance or rim profile balance. I think, perhaps when the procedure started, you were just trying to get it to look good on an AP and a false profile X-ray. But a lot of attention is paid now to the orientation of the walls and the version of the fragment, and really kind of checking your motion and making sure you have preserved as much flexion and internal rotation as possible. So on a very basic level, you're looking for a level source seal. You're looking at your anterior center edge and your lateral center edge angles. You're verifying lateral coverage by looking for elevation of the pubic ramus. You're looking at your rim index and make sure you've recreated a balance between the anterior and posterior rims. And you're checking for impingement, both intra and extra-articular. In terms of closure, oftentimes the rectus can be closed with a single stitch or 2 stitches through bone tunnels. Ben utilizes a lock and crack out technique for this. The capsule can be shifted with an open shift, which we have described. You can perform bone grafting of the iliac wing and the pubis cut, and I typically will place drains in obese patients. In terms of rehab, with a lot of patients, we'll still use an epidural for 24 hours. We're starting to get into some regional blocks. Crutches are typically used for 2 to 3 months, chest deep water at a month, waist deep water at 2 months, and usually unlimited walking by 4 months without crutches. And I think that in addition to the technical challenges of the surgery, sometimes it's challenging to guide these patients throughout the rehab. You have patients who have delayed healing, and managing that sometimes is tricky. Patients often are running at 5 months with screw removal at 6 to 8 months. In terms of the lessons that I've learned over the years, hips can be unstable with normal x-rays. So you can have a patient who's got pretty normal looking x-rays, but if they have, say, a deadly combination of ligamentous laxity, heightened femoral anteversion, and a reduced anterior wall profile, those patients can be extremely unstable, even with a normal lateral center edge angle. Of the cases that I've seen, the failures that I've had, cases where if someone's calling for the microfracture alls, then that's definitely a bad prognostic indicator, unfortunately. I will never again operate on a patient that smokes, even with a history of smoking. I now tell people they have to stop 6 months at a time, just because the biologic impact of that is there's a lot of residual slowdown in terms of healing. And the challenges I've had with non-unions have all been in smokers. We try and address vitamin deficiencies, in particular vitamin D preoperatively, hold birth control to reduce your risk of VTE, 2 drains in obese patients, and I really try and outline expectations very clearly in advance. Perhaps some might say I paint a picture of gloom and doom, but then I just have them see Ben the eternal optimist, and it makes it all better. So in terms of evolving indications, I've got to hustle a little bit here because I have to go to the OR. We know that untreated hip dysplasia with a lateral center edge of less than 16 or a tonus over 15 is going to lead to a total hip by age 60. That's old data, but newer data would suggest that, probably these indications for a PAO are even broader, with a tonus over 8, lateral center edge over 25. Those things are going to put you at an increased risk of developing hip arthritis, as well as a number of other parameters. Patients always ask about outcomes. I think Dr. Millis's data, and then one of his kind of famous quotes to patients is always helpful, easy to remember, and easy for patients to understand. If you take 100 patients who have a PAO at 20 years, 50 of them will be asymptomatic. 25% will be better, glad they had the procedure, but some level of residual symptoms, and 25% will have failed at 20 years. So there's a limitation to the procedure. I always tell patients we can't make your hip normal. We can't take all your hip pain away. But I think they're, at 20 years for patients with bad dysplasia, 75%, hip preservation rate is still pretty good. In terms of the first PAO patient, it was 34 years before Dr. Millis had to convert it to a total hip. In terms of return to sports, 80% will return to sports, 71% to their prior level. It is lower in competitive athletes, but there's a lot of newer data coming out on this. This is probably still controversial. Just remember, there's limitations with arthroscopy alone. These are cases that were referred to Ben and I. This is acquired hip dysplasia. Just be careful in your ligamentously lax patients or patients with elevated femoral anteversion. This is a patient with Ehlers-Danlos, pretty subtle dysplasia, but she really had an isolated anterior wall deficiency, kind of an anteverted acetabulum. And she had, I think, four surgical dislocations, which is crazy. So these are the type of things that we see when we 3-dimensionally visualize failed hip arthroscopies. These are cases that were sent, and you'd look at the x-rays and say they're pretty normal, but then there's a big bite out of the anterior wall, which is really the root cause of the instability. Some of these failed hip scopes are challenging, and not all of them have a solution in a PAO. But I thank you for your time, and I can take a question or two, but I got to hustle off to the OR.
Thanks, Justin. That's great. If you got a question or two in, yeah, I'll start with a battery of them. One, we just came back from Isha in Scotland. So 2 minor technique things I saw there. I wonder if you've seen. One was a tip oscillating saw for the iliac cut instead of one that oscillates in its entirety. And the other is a vice grip that goes on the shanse pin that actually abuts against the fragment. So it seemed like it might have a better grip on the fragment than the T handle. So A, have you seen either of those things in any opinion? And B, do you think with the masked osteotomes, there has been a blurring of the line between a PAO and a spherical osteotomy? Are we making it a little more spherical than originally described?
Yeah, in terms of the, you're probably talking about something like similar to the Stryker precision blade that they use in total joints, where it's just the very tip that oscillates. Yeah, that's a good technical consideration. The problem with that is that it sometimes can bind up in hard bone, which is, so it'll be good at the beginning, but as you get deep into the iliac wing cut, you may find that that binds up and doesn't give you the degree of cut that you want. In terms of the vice grip, yeah, I think anything that kind of more closely approximates your kind of grip point to the bone is good. A lot of people will use a kind of a lobster claw along with the Schons to achieve a similar impact. And then I think you're really spot on with your discussion of the sphericalization of the PAO, especially with kind of more difficult, or I would call them less ordinary corrections. Anteverting PAOs, reverse PAOs, it's really helpful to round out that posterior column so those hard corners aren't pushing you during a correction. And so yes, to the third question.